Hey, good evening, everyone. It's my pleasure to welcome you to tonight's session of our Holistic Health Speaker Series. This initiative is designed to explore the powerful connection between mental and physical health, offering expert insights and practical advice to promote overall well-being. Before we begin, I'd like to take a quick moment to share about NAMI-FLNY. All of our programs are free and peer-led and guided by volunteers with lived experience. Our mission is to provide support for families, relatives, and friends of individuals diagnosed with mental health conditions, to educate our community about mental health, and advocate for those impacted. Together, we're working to build a community of hope and understanding. I'd like to extend my heartfelt gratitude to one of our volunteers, Dr. Francesca Ballata, who has been instrumental in bringing exceptional speakers in for this series, ensuring we continue to offer valuable learning opportunities to our community. A quick housekeeping note, tonight's session is going to be recorded and made available on our website. To ensure the best experience for everyone, please mute your microphones during the presentation. If you have questions, feel free to submit them in the chat or send them directly to me if you don't want them associated with your name, and we'll have a Q&A session at the end. Now, it's my pleasure to introduce tonight's speaker, Dr. Cris Haltom, who brings a wealth of expertise as a certified eating disorder specialist and licensed psychologist with a long-standing private practice in Ithaca, New York. She has served as part-time psychology faculty at Ithaca College for 10 years and has authored 2 notable books on teens and eating disorders. She has been a consultant trainer for eating disorder treatment professionals, including at the Healing Connection and University of Rochester Medical Center in Rochester, New York, and has led national and international workshops on teen eating disorder treatment, most recently for the American Psychological Association. Tonight, she will share her extensive knowledge and practical guidance on understanding and addressing eating disorders, offering valuable insights for individuals, families, and professionals. With that, it's my pleasure to hand things over to Dr. Haltom.
Good evening, everybody. I'm happy to be here. As I was saying to the early comers to this meeting, I'm fairly enthusiastic about this topic, so that will come through. One of the downsides of my enthusiasm is the amount of information that I try to put across. So I've cut out a number of slides, and each topic that I go over related to eating disorders will be kind of a reduced version of a much more extensive knowledge base in all of the areas that we're going to talk about. For Liz, I guess you're just coming on. I asked everybody if there was anything in particular that you really were interested in hearing about tonight. You don't have to identify anything, but if there was something, I'm happy to write it down and make sure I hit it.
Sorry, there's a lot of noise in the background here, but I'll ask any questions as you give your information. I'm mostly interested in school-age children.
Okay. That will be easy since the vast majority of eating disorders are school-age children. So I think I'm going to have to use the arrow here. We go. Okay, so overview. These are the topics that I hoped to talk about tonight. How prevalent are eating disorders, and particularly in our country, defining the different eating disorders and a feeding disorder, who is on the treatment team, and that will help to address Francesca's question, because eating disorders are multi-dimensional. They involve just about every area you can think of in healthcare. So the treatment team tends to be more complex with eating disorders than with other mental health issues. Risk factors and etiology of eating disorders. Then what is it like to have an eating disorder? There's a whole lot to say about that, so I'm just going to kind of hit a few primary or common experiences that people with eating disorders have. I'm going to overview very briefly some treatment approaches and talk about recovery and relapse rates. Oops, wrong way. Okay. So The National Eating Disorder Association reports currently that about 9% of the US population is going to have an eating disorder in their lifetime. It's about the same as post-traumatic stress disorder, actually. So over a lifetime, 95% of eating disorders will start between ages 12 and 25. They can start at any age, but almost all, as you can see, start at a very young age, at school age. 13% of teenagers will develop an eating disorder by the age of 20. The National Institute of Mental Health points out, as every conference I've been to that gives a general overview of eating disorders, that anorexia nervosa in particular is associated with dying early, 18 times more likely to die early, the most devastating of the mental health diagnoses with regard to early death by suicide or because of medical complications. So what are the different kinds of eating disorders? First of all, anorexia nervosa, probably the most famous of the different kinds of eating disorders in terms of the various public figures that have struggled. It's fairly obvious when somebody has a severe restrictive eating disorder because of extensive weight loss. So it used to be that the diagnosis of anorexia had a sort of cutoff for weight, that you had to be below like a BMI of body mass index of 18. That is no longer the case. It hasn't been true for over 10 years. It's just the failure to gain expected weight or to be in a healthy weight range, regardless. And it involves restricting food, and it always involves body image distortion, people seeing themselves as being larger than they actually are and disliking their bodies. A second kind of eating disorder is bulimia nervosa, and that involves binging and purging. People ask, what is a binge? So a binge is an inordinately large amount of food eaten in a discrete period of time, like 2 hours, and then using some compensatory behavior to get rid of that food in order to manage weight. So purging could include vomiting, laxative use, diet pills, excessive exercise. The thinking with bulimic thinking is calories in, calories out. If I eat and I'm trying to manage my weight and keep my weight down, how can I get rid of those calories? Binge eating disorder is like bulimia without the compensatory behaviors. So it's binge eating at least one time a week for a period of extending at least 3 months to receive the diagnosis. A question that often comes up is with extreme overweight, especially where there's healthcare complications. How many folks with what is medically known as obesity, we're a little sensitive in the area of eating disorders using the word obesity because it implies a kind of fat bias. But using the medical term of obesity, about 30% estimated, depending on the research study that you look at, 30% of those with morbid, medical morbid obesity have a binge eating disorder. The other 60 to 70% do not. There's other specified eating disorders, and that's where it's sub-threshold. Often people are meeting most of the criteria for anorexia, bulimia, or binge eating disorder, but there may be one symptom that's missing, like a purging disorder is a lot like bulimia, but a person isn't necessarily binge eating. That would receive a diagnosis of OSFED or other specified feeding or eating disorder. And then there's unspecified feeding or eating disorder where people are having dysfunction related to disordered eating, but it's very low level and a little hard to fit into any diagnosis. There's been a lot of attention paid recently to the feeding disorder of avoidant restrictive food intake disorder. Average age of diagnosis is age 11. And this is where people have malnutrition, restrictive eating, but it does not involve body image distortion or negative body image. It may be because a person has a fear of choking, or they are having sensory issues around food, the way it smells, the way it looks, etc., and they end up restricting. So here's some of the overview statistics. Oops, I went in the wrong direction again. Okay, here's the treatment team. So as you can see, it's complex because eating disorders are multifaceted, multidimensional. So for all the dimensions of eating disorders, we need a treater who is specialty trained in eating disorders. So on the treatment team, collaboratively, is the person with the eating disorder, including young people, their family, the carers and the family members, a dietitian, and the dietitian will play different roles depending on the model of treatment that's being used. The psychopharmacologist, there is no medication for any of the major eating disorders. However, there are common medications that are used to help the auxiliary symptoms, like anxiety happens almost across the board with eating disorders, particularly anorexia nervosa. And so even though the medications aren't as effective related to malnutrition, people will often be taking hydroxyzine to help lower anxiety, particularly around eating, and or a serotonin reuptake inhibitor like Prozac. People with binge eating disorder, people have used Wellbutrin, Vyvanse, which is a stimulant medication, seems to help with inhibit the binge eating. So again, no medication specifically for any of the eating disorders, but trying to at least lower the intensity of some of the uncomfortable symptoms with medication. So it was often a psychopharmacologist, either a nurse practitioner, psychiatric nurse practitioner in Tompkins County, because we don't have a lot of psychiatrists that are available, or the PCP, the family physician or pediatrician. In addition to the mental health workers, such as myself, a social worker, licensed counselor, specialty trained in eating disorders, many people who are in treatment are using food logging or a recovery app. There are several vetted and good ones on the internet these days, such as Recovery Record, where people will log their food for the dietitian and or the therapist. It can include taking pictures of the food in order to keep track of it. And the reason to do this is twofold. One, people who are in recovery need to be objective about their food intake. And two, eating disorders psychologically do not want to be revealed. So there's a tendency to hide symptoms, and food logging or using a recovery app and reporting on those apps their food intake exposes the eating disorder to the light of day and actually helps with recovery. So why do we need specialty trained people in the field of eating disorders? First reason is multidimensional disorder. I need to be able to know how to work with a nutritionist as well as medical managers. They need to know how to work with me. So we all need to be a little bit cross-trained in each other's areas to understand our roles and to keep our roles separate but coordinated and collaborative. It is particularly difficult with eating disorders because a high percentage of people with eating disorders have comorbidities. Jean had asked about that. And so we have to know how to triage the behaviors. For example, with anorexia nervosa, it's very hard to treat any kind of psychological or psychiatric disorder alongside of the anorexia because the neurological consequences of malnutrition are so impacting the brain that there's not a lot of ability to really take advantage of usual psychotherapy for for eating disorders. So somebody who's specialty trained knows how to triage, knows how to combine the focus with comorbidities. These clients are really hard to treat because, especially with things like anorexia nervosa, there's often a desire to avoid treatment and not have somebody meddle in the course of the illness. So motivation is key. Quick example is somebody that I worked with who had 11 years of bulimia nervosa, close to mother and father, living at home, and had never revealed and kept the bulimia completely secret until one day when she was living with her roommates at like 18 or 19 and passed out and was taken to the emergency room, and it all kind of came out. So the desire to keep the illness and the behaviors and the thoughts about eating disorders secret is strong. As I said, there's a lot of comorbidity. The recovery moves very slowly, which is also hard for a lot of treaters. The physical condition is often impeded by the psychological condition, like you can imagine with obsessive compulsive disorder. If somebody has OCD around food contamination, it can easily get in the way of renourishing with basically all of the eating disorders. Another piece of very recent evidence that's relevant here is that the average parent takes their children or their teens to 3 to 4 providers before they actually get effective treatment. And that's partly because they're not taking their children or teenagers to specialty trained providers. So the treatment tends to not be great. But also, there's a belief when a person goes into therapy, they need to click with the therapist. And if most young people between the ages of 12 and 20 are avoiding treatment or they're ambivalent at the very least, you can easily imagine that they reject the initial attempts at treatment. So here's another really interesting study that happened in 2024. These are nurses talking about what it's like to work with somebody with an eating disorder on a general psychiatry inpatient unit. And this was based on interview and questionnaires. So the nurses were complaining they lacked the specialty training, especially around renourishing and feeding people with an eating disorder on their unit. The toll that it takes to have resistant patients on an inpatient unit, and people with eating disorders are often resistant to intervention, as I've been saying. And also they found that many times the nurses in this study were blaming the young people with eating disorders as just not having willpower or seeing the eating disorder as a choice. There's a saying in the field of eating disorders, it's an illness, not a choice. I wanted to make you aware, thinking about the people on the treatment team, and it was in that diagram that I showed. I'll explain now, eating disorder coaches. So this is a relatively new injection into the treatment team. And these are mentors who've actually had eating disorders themselves, who kind of bridge the gap between therapists and dietitians, friends and family. These people, these mentors, these coaches, who are not covered generally by insurance for outpatient work, they are often included in higher level of care for like an online intensive outpatient program or partial hospital program, and it gets billed to insurance as part of the treatment team. But for outpatient, I've had a few people who've hired coaches. They've been very helpful, and I'll explain what their qualifications are. But they've had to pay for them by the hour. So this is relatively new. Research has shown that they can be effective. Therapists and dietitians run by the usual medical model. They have an appointment time. They come in once or twice a week. The appointments are anywhere from 15 minutes to an hour for dietitians, 45 minutes to 60 minutes with therapists. Coaches make themselves available at all kinds of times, like supporting a meal. They may support all 3 meals a day. These individuals, as you will see in this next slide, have all had eating disorders themselves. They do, in one program, 35 hours of training online. They are at least 18 years old. They've had lived experience with an eating disorder, and they've had no behaviors for 2 years. So they have to be solidly in recovery. And they are getting some kind of supervision. So coaches can be anywhere. They can be on the phone, online, in the home. A lot of this is done online and started really becoming a very common part of the treatment team during COVID, when a lot of treatment went online, because it was easy for a mentor or a coach, an eating coach, to be somewhere else in the state of New York and talking to a person at a distance. I've had coaches receive calls any time of the day. I feel like binging right now, the person with the eating disorder, and then the coach helps them walk and talk through it and not engage in the behavior. Meal support is a really common role, where the coach is online with the person who is trying to get through a recommended meal. Okay. Somehow, here we go. Developing the eating disorder illness. So unfortunately, very few women in particular, but also men, have full body acceptance. It's really common in our country and really across the world to have body dissatisfaction. So we have this small number of people who fully accept their bodies and are not concerned with their body being unsatisfactory. When people do have body dissatisfaction, which is probably the #1 contributor to developing an eating disorder, young people will often get into disordered eating. Something like, oh, I'm just not going to have any sugar today, or I'm not going to eat until dinner. Some small attempt to diet, and it often just falls off because people get hungry. However, sometimes, depending on the risk factors, a person may develop a full syndrome eating disorder, or even a severe enduring relapsed eating disorder, or really an eating disorder that does not get better in any way from first diagnosis. So some of the risk factors are being exposed to the constant sociocultural demands of social media of the idealized body image, and or the barrage of information from the wellness world about healthful eating, and some do not handle it well. So they maybe haven't had a parent at home who's helped them dissect the media that they're seeing and recognize that these are doctored images, they're not realistic. And some people take what they see in social media as very important in their life. So when I ask somebody with an eating disorder how often they think about their body image or something related to their eating, related to weight management, it can be as high 80, 90, 95% of their waking hours. So it becomes obsessive at a certain level. It can also become obsessive about healthful eating, and I'll say more about that in a minute. So having obsessive compulsive disorder, about 35% of people with anorexia nervosa have obsessive compulsive disorder, which is usually pre-existing. And the two get along quite well. Anorexia with food restriction and all the food rules that go with that, and obsessive compulsive traits. Having a higher BMI, because a higher BMI, body mass index, is not that idealized body image. So people with higher BMIs, larger size bodies, often dislike their bodies more And as I said, body dissatisfaction is the #1 contributor. So the young people who don't like their bodies are more likely to get into dieting and weight management, which in turn gets them potentially into an eating disorder. Genetics. I routinely ask now, did anyone in your family have an eating disorder? High genetic transmission for eating disorders. I am always thrilled when I have a parent sitting in the room who's been there, done that, especially if they're fully in recovery, but they've been there in the past, because they can be so helpful in understanding what their teenager is or their child is going through. Puberty. So especially for women, puberty seems to kick off a higher level of intensity of negative emotion around body dissatisfaction. The average age for starting to really verbalize disliking body seems to be about 10 in the 5th grade. Middle school for 12 years old for actually having behaviors. So the ideas and the body dissatisfaction kind of foment, and young girls speak to each other about this. I feel fat. I don't like the way this looks on me. It makes me look fat. I can't eat this. I can't eat that because it'll cause me to gain weight. Being trans often creates issues for people, centered on the body, and the body changing from looking like one gender to looking like a different gender. So it's no surprise that trans women are 10 times more likely to develop an eating disorder than cisgendered women. It is also true that trans men are more likely to develop eating disorders than cisgendered men. Being an athlete, we've known this for 30 years. Some old studies looked at D1 athletes, Division I athletes, and the rate of eating disorders in college among D1 athletes was much higher than average for colleges. Part of it is performance anxiety related to weight, and some of it is appearance anxiety related to the particular sports, like athletic sports, gymnastics, ballet, where people are more self-conscious about how they look, or the sport itself seems to have an ideal body type that may not be a person's ideal body type, like ballet. And then they want to mold and shape their body to be like that ideal athletic body for their sport. I just threw this slide in recently because there's an important point I think to make. So this is a slide from Psychology Today where they look at the occurrence of mental health disorders in general. So plus or minus 1 standard deviation from the mean on the bell curve with most mental health disorders is not meeting criteria for a mental health issue at any particular point in time. So not true with eating disorders. The average person has disordered eating. And it's way out there at the end of the tail on the bell curve that you have people with body acceptance, which is where we want people to get in recovery, is to get beyond all the idealized media images and to feel good about one's body. Unfortunately, 90 to 95% of women in particular, and a huge portion of men, do not like their bodies. So the majority of people, especially women, have some disordered eating. Where do we see the biggest increase? There was a dramatic increase in eating disorders during COVID isolation and quarantine. The number of hospitalizations went way up, even though people were avoiding hospitalizations during those years, but this was a high priority inpatient situation because the health consequences of eating disorders can be severe. The biggest increase in symptoms in a study that was done in 2022 was between ages 12 and 15. So the number of eating disorder thoughts and behaviors just catapults between 12 and 15. The problem is most prevention programs are geared toward older high school students. So one of the thoughts here is we need to get to them a little bit earlier. The highest rate of eating disorders in Asian countries is in Japan. And the thought is that there's a uniquely strong pressure to be a particular brand of thin. A lot of dieting trends in Japan and a lot of weight loss products. In 1993, I went to the World Congress for Mental Health in Tokyo, and I had a chance to sit with two English-speaking psychiatrists who shared with me a method of thinning that I'd never even heard of before, anecdotally speaking. It was, and I don't know, maybe some of you have heard of this. You take a piece of cardboard with tin foil wrapped around it, and you sit in the sun, and you fold it so the sun is facing your face, and it sweats your face smaller. So this would be an example of a dieting trend. Looking at different ethnic and minority groups, because the question often comes up, the eating disorders occur at different levels of prevalence in different ethnic groups. And basically, this study in 2019 showed that there really were not any statistically significant differences in eating disorder onset among the different ethnic groups in the US. It depends on the study that you find. You'll find a study that says Black women don't have as many eating disorders. You'll find another one that shows that Asian women have more eating disorders. But if you look at a multi-study data, you will find that they sort of cancel each other out, and that there are risk factors that affect every ethnic group in the United States. And while, yes, in some populations, you may see more in one ethnic group and another study is going to find something else. So I said that lifetime eating disorder prevalence rates have actually increased. So 3.5% increase between 2000 and 2006. Then between 2013 and 2018, 7.8% increase. And currently, as I've stated earlier, it's about 9% over a lifetime. I have to stick this in here because this is such a popular area in eating disorder research right now, which is intersectionality of mixed identities. And just to show you how this goes, see if I can get this out of the way here. I can't altogether. Oops. I'm going to move this back. Okay. So this was a study of graduate students and undergraduate students in the United States. They looked at socioeconomic status, gender identity, sexual orientation, race, and ethnicity. And the participants were screened for eating disorder risk. So what they were doing is combining different identities and just to show you how this research comes out, the most common or the highest level of eating disorder risk was found among people of lower socioeconomic status, Latinx background, sexual minority, bisexual men, and lesbian women. It's the combination of all those identities. So it's not necessary to necessarily think about these mixed identities and the occurrence of eating disorders for the purposes of this presentation. But I just wanted you to know that that is being looked at because a mixture of different identities does suggest some different approaches for treatment. Little bit about ARFID, or avoidant restrictive food intake disorder. Oops, okay. I want to get myself back to. No. How do I get myself back to that little bar? Hide the meeting. Well, okay. Somewhere in here, I'm gonna get a chance to look at the chat. So a little bit about ARFID. As I was saying, it is failure to meet normal nutritional needs. Some people get so far into ARFID that they need enteral feeding or feeding tube, and the ARFID, as part of the diagnostic criteria, needs to interfere with people's psychosocial functioning. As I said, it does not involve body image concerns. So often when we're trying to figure out the difference between somebody having anorexia nervosa or ARFID, we will ask about body image. It is more common in boys. I've seen plenty of girls with ARFID issues. ARFID is a risk factor for developing anorexia nervosa. So it is, for my practice, it's been common enough to find people who had ARFID as younger children, and it evolved into anorexia nervosa with some of the ARFID characteristics still intact, like the fear of vomiting, emetophobia, fear of choking, or having sensory issues around food. So there are these different types that are listed here below. I want to talk a little bit about orthorexia because it is coming out a fair amount in the media. And that is a fixation on healthy eating, pure foods, clean eating, quality of food, very, very important, different than anorexia nervosa, but certainly a risk factor for any eating disorder. The focus is on the quality of the food, and it can easily get restrictive. So characteristics of orthorexia, not an official DSM-3 or DSM-5 diagnosis, but still important for people in the eating disorder field to know about. Constantly checking for ingredients or nutrition facts, cutting out foods that are deemed to be bad foods, like sugar, white flour, being anxious when healthy foods are not available, obsessively following a healthy lifestyle, oftentimes following social media accounts and blogs that speak to orthorexic concerns, like do this, avoid sugar, etc. People may cut out entire food groups, and you can easily see how if this happens, it can lead to restrictive eating disorder. I need to just point out something that's interesting. In the early years of eating disorder treatment, we used to say in residential treatment that people had to stop their vegan and vegetarianism and eat meat because protein was needed. That is no longer the case. Residential treatment facilities will now support vegan and vegetarian eating. Want to say a little bit about diet culture because it is so influential in body dissatisfaction. This is a picture from a blog about clean eating. A lot of touting wellness influences, presenting recipes that will help people eat cleanly, avoiding dining out because dining out food is considered to be sort of not clean eating, too much salt, too much fat, too much sugar. And as I said, compulsively checking ingredients in food. So this is a blogger for clean eating. When COVID happened, the amount of time that young people, middle school and teenagers, were spending online outside of school hours went from 3.8 hours a day to 7.7 hours per day on the average. That meant more and more exposure to social media platforms where people were idealizing certain body image, posting information about dieting, posting information about food they were eating in order to manage or lose weight, exercise videos, and very detailed recovery journeys. This is an example of a TikTok, the Corpse Bride Diet, that came out at the end of 2021. So on this TikTok video was somebody talking about how to diet, tips about eating less than 300 calories a day, recommending water to fill up so you didn't want to eat, using laxatives after eating too much, videos of rapid weight loss competitions, where a group of young people would get together and see who could lose the most weight, reporting weights to each other, body shaming, like putting up photos of larger sized people and saying really kind of horrible things about them, and pictures of emaciated folks, especially zeroing in on certain body parts like a hollowed out shoulder with sort of hollowing around the bones, looking particularly emaciated. Unfortunately, because of For Your Page function with social media, a lot of, and we all experience this, we get videos, we get links to content that the computer has already figured out we are onto. So if somebody is looking at these diet-oriented social media sites, they're going to attract more and more references to similar sites. So I'll just skip to something that I was involved in. So I did a study when I was at Ithaca College about the relationship between those who had more face-to-face interaction with other young people versus people whose interpersonal communications were more geared to online. And we did find a significant effect of digital interpersonal communication over face-to-face in terms of eating disorder risk. It's almost become intuitive at that point for that to be true. One of the reasons that limiting social media exposure is eating disorder prevention. So what is it like to have an eating disorder? Body dissatisfaction. So young people with eating disorders are very prone to looking at themselves in a mirror or a reflective surface and dissecting their bodies as they look, often focusing on a body part that they think is too large, like stomach is probably the most common, but it could be arms, legs, rear end, face, and examining the flaw for looking too large and becoming obsessive and seeing flaws where other people don't see them. In terms of treatment, there is no arguing with an eating disorder. It is completely in vain to say, you're not fat, or I don't know what you're talking about, because people see what they see. So there's an acceptance on the part of treaters that people are seeing what they're seeing. And with improved body image, just feeling better and better about their body, and improved eating, a lot of that distortion melts away. It may be the last thing to go, but it gets better over time with treatment. Trouble eating, because eating is related to weight and feeling larger, potentially larger. So struggling with food, isolating out certain foods that a person is not allowed to eat. A common one that I'm sure you're familiar with and have read about from accounts of eating disorders as well as the wellness industry is having a pizza and taking a paper towel and blotting out the fat in order to avoid fat. And if I ask somebody with an eating disorder, young person, 12 years old, 16 years old, why do you not want to have butter on your potatoes or fat on your pizza? It's because the fat will go to my stomach. The fat will make me fat, and I don't want that. So many of the beliefs around isolating out groups of foods are distorted, if not completely untrue. The body, in fact, needs fats, we even have enzymes to break down saturated fats. So a fair amount of treatment is psychoeducation about what science has to say, not denying what the person is saying, their beliefs, but just offering an alternative. Guilt about eating. So everybody with an eating disorder, whether it's anorexia, bulimia, or binge eating disorder, because they're very focused on the relationship between food, exercise, and weight management, associate eating with guilt. For somebody with anorexia nervosa, just the feeling of being hungry can initiate feelings of guilt. For binge eating to the point of being uncomfortably full, one of the symptoms of binge eating disorder is having guilt after having a binge. It is also true with anorexia and bulimia. If somebody's eaten a food they consider to be a quote unquote bad food, they become guilty. So tip about collaterals here. We work with families and friends. If there's a good friend that happens to be involved in supporting a person in recovery, we work with them to do away with things like good food, bad food thinking. The thought is all foods are equal, everything in moderation. So it's not that Crisco in a can is a bad food. It's to be eaten in moderation. Or candy, or Cheez-Its, or cheese curls. There's a place for all of these foods in moderation, and the focus is on nutritional balance. This is a very brief eating disorder screening device that's often used in research. It's very brief. It easily fits into a slide. That was developed some years ago. And these are some key questions that we might ask in diagnosing any disorder. Do you make yourself sick because you feel full? Do you worry you've lost control over how much you eat, which is another characteristic of binge eating, feeling like you're losing control? Have you lost an excessive amount of weight? In this case, 14 pounds in a 3-month period. Do you believe yourself to be fat when others see you as too thin? And would you say the food and eating dominates your life? I can provide this slide to anybody that's interested. Now, to speak to Jean's question about comorbidities. So 55 to 97% of people with eating disorders, depending on the study you look at, have at least one other diagnostic label. Because we're going to end up running short on time, I won't go through all the statistics, but you can see here that anxiety is very common, obsessive compulsive disorder, social anxiety, all the anxiety disorders are common. Depression, very, very common. One of the reasons I think depression happens with malnutrition or not having enough is the brain is not getting enough of the nutrients that it needs and is not producing serotonin at proper levels for good mental health and not being depressed. Here's some more comorbidity rates. You can see with binge eating disorder, I broke down the statistics between teenagers and adults. And here are the many comorbidities. The question often comes up when I've done clinical trainings, well, what do we treat first? The eating disorder or the comorbidities? And depending on the model of treatment, you can't ignore the eating disorder. It has to be dealt with up front because it gets in the way, as I was saying earlier, of addressing the other issues. It is possible to deal with both at the same time. So a person might have a goal around balanced eating, 3 meals a day, 2 to 3 snacks a day, meals 4 to 5 hours spread apart is a typical goal for eating disorder recovery from both dietitians and therapists. And we may be monitoring that alongside of dealing with somebody's OCD symptom like food contamination in the kitchen, or having to touch pieces of furniture so many times before leaving the house. We don't want to make things too complicated, but again, a little like in the alcohol field, it's important to address the eating disorder because it very much gets in the way. I'm currently dealing with somebody who's got alcohol dependency, anorexia nervosa, and depression and anxiety. And we've chosen to triage out the alcohol first because we can't really get at the eating disorder very well. But at the same time, we're doing a little intervention around the eating disorder. Behaviors can evolve, transition over time. So somebody who starts out, let's say they start out with ARFID as a young child, and they drift into anorexia nervosa. They get into treatment, and their treatment has them eating more because renourishing is important with every form of eating disorder. And because of the fear of gaining weight, a person with anorexia may start vomiting. They may be gaining weight and getting into a normal, healthy weight range, but they've turned to purging, and because they're terrified of the weight gain, and it gives people some sense of control. So they drift into laxatives, vomiting, excessive exercise. We in the field have to be trained to recognize people pulling in compensatory behaviors as they recover, because those have to be addressed as well. And people drift from one diagnosis to another. People with chronic enduring issues have often had bulimia at some point in their life, anorexia nervosa at some point in their life, and binge eating disorder at some point in their life. And hopefully they have gotten treatment for all of the behaviors that they are exhibiting. So most partial syndrome eating disorders resolve without evolving into full eating disorders during the mid-teen years. However, I explained how early symptoms at around 12 years old can also evolve into a full-blown eating disorder. ARFID occurs at about 5% of children, which is high. And because of the malnutrition, often results in a hospitalization. Eating disorders can occur in older adults. In the literature and in the research, it's onset after 30 or 40 that's considered late onset. So about 2 to 7% of older women have eating disorders. Who seeks treatment? I'm going to also go quickly through this. So we have a big problem in this field, and that is that people are not seeking treatment. As I said, there's a desire to keep people, treaters out when a person has an eating disorder, and for them to want to protect the eating disorder. Only about 20% of teenagers with diagnosable eating disorders receive any kind of specialized treatment. Many of them have had contact with the health service sector for other emotional and behavioral problems, but only a certain small portion of them ever spoke to their professional treater about their eating disorder problems. It is more easily discovered if a person is unusually emaciated or off their growth chart, their pediatric growth chart. They've fallen down, and the pediatrician might catch it. Or a person may have been caught purging. But short of that, eating disorders are not that hard to hide. And for someone who's not motivated, it can be difficult to discover it in children and teenagers. Adults seeking treatment, even in adulthood, there is low treatment seeking. What are the reasons for not seeking treatment? People are often not aware that the treatment is out there, or they think it won't work. A big issue that resulted in an organization in Rochester to train medical providers, that's ongoing to this day, is healthcare providers who do interface with our young people with eating disorders, but they didn't detect the eating disorder. So like the young woman I told you about who was had purge behavior at least once a week, if not more, from the time they were 12 all the way through high school. The parents didn't know, the pediatrician didn't pick it up because they hid it so well. And the right questions would have probably surfaced the eating disorder. I find that when I ask specific questions of someone with an eating disorder, do you restrict your food? And I define restriction. Are you throwing up to get rid of food? Do you exercise? Are you motivated to exercise to manage weight? People are generally honest. There's also a stigma surrounding eating disorders, and in general, the stigma around seeking treatment for any mental health problem. Levels of care. So quickly, the lowest level of care is outpatient. By the time somebody gets to outpatient treatment, they've usually been online these days, and there are some excellent resources. National Eating Disorder Association, NEDA, is an excellent resource. International Association of Eating Disorder Professionals is an excellent resource. The Academy of Eating Disorders, the National Institute of Health has very good information about eating disorders. So I think this is great that this is occurring because people are then more aware of treatment and they have good psychoeducation. Sometimes outpatient is not enough. And outpatient, as I said, would involve a dietitian, possibly medication, psychotherapy, and a person might go to intensive outpatient, which is usually anywhere from 2 to 5 days a week for 3 hours a day, usually covering at least one meal. These days, a lot of IOP programs are online. Next level up is partial hospital, which is basically not sleeping at a program, but in every other way is like a residential program. Could start at 9 in the morning, could start as late as 11 and go through the entire day, often covering at least 2 meals, often going right into Saturday. Higher level of care than that is residential treatment, which is live-in, anywhere from 3 to 6 weeks, depending on the program. We have about 80 residential treatment programs in the United States. And then the highest level of care is inpatient hospitalization, and that occurs when there are medical complications. The nearest one is an eating disorder unit at the University of Rochester School of Medicine. And I believe at this point in time, it is a 17-day program. A person might move down step to residential from inpatient, or they might move to a partial hospital program. So, as I said, there are nutrition counselors and psychotherapists. Just quickly, the difference between the two. So nutrition counselors often cross over with psychotherapists. We all talk about eating patterns. We talk about food. We talk about diets. We talk about body image. We talk about purge behavior, all the compensatory behaviors. We all try to identify eating disorder triggers. Psychotherapists, in addition, are dealing with the comorbidities and are usually the ones to be doing the family work. I'm going to breeze through the main biology maintaining factors. So one of the dilemmas in eating disorders is which came first, the chicken or the egg? Is it neurology first, biology first, or is it psychology first? I presented it as if psychology is first, but a really interesting study done many, many years ago showed that if you starve people down to roughly 25% less than their original weight, they will look exactly like someone who appears to have a psychologically based anorexia nervosa. So this is the brain reward system, and we know with anorexia that the brain, without getting into the details here, for somebody with anorexia is all about rewarding not eating, because the thought of eating or eating certain food raises anxiety. The brain remembers what foods to avoid, and then there is motivation to avoid that food in order to reduce the anxiety. And that's just the different parts of the brain involved in a simplistic manner. This is a very interesting new piece of research. A discovery this year of two neural knots in the amygdala, or the emotional control section of the brain, that when those knots are activated, suppress eating and appetite, encourage activity and over-exercise. And there's some thought that whatever these neural knots are involved in the development of anorexia nervosa. Binge eating. This one you may already know about because there's been a fair amount of press about it. So stress leads to blood sugar going up, insulin levels falling. The higher blood sugar level, which is meant to energize the body to face the stress, increases food cravings. So hunger and appetite increase. And for the quickest energy, there's a turning particularly toward fats plus sugars, carbohydrates. This in turn takes attention away from processing stress and related emotions in other ways. The dopamine release from eating the sugars and the carbohydrates is then rewarding the brain and leads to more eating, which in turn leads to the guilt of overeating, which in turn is stressful. And we have this cycle going on. We do know that with binge eating disorder, the hunger stimulating hormone ghrelin falls more slowly in those with particularly high weights. Really quickly about treatment and recovery. These are the 8 key steps to recovery, no matter what model of treatment is being used. Carolyn Costin is a well-known figure in the field of eating disorders, wrote a book about the 8 keys to recovery from an eating disorder, and they all make total sense to me. They are all of these steps are included in any kind of treatment. First of all, we have to help the patient understand the disorder. We have to help them with motivation to recover. For example, a really common motivation to recover is with restrictive eating or of any kind, and it could occur with any of the eating disorder types, is muscle loss because of not eating the fuel that is required to build muscle. Many people want muscle, so that can be a motivating factor. Challenging all the thoughts, urges, and actions that go with the eating disorder, like restricting, like purging, leading to learning to re-nourish, key. Learning to deal with emotions in ways other than leaning on the eating disorder as a coping strategy. Eating disorders in general operate as emotional anesthesia. Always a focus on body acceptance and body respect. Teaching people media literacy and critical thinking about idealized body images in the media. Understanding and dealing with the past when there are old psychological dilemmas, trauma, for example, that might have led to leaning on the eating disorder as a coping strategy. And then finally, building a life and a self outside of the eating disorder. These are some of the timeframes for recovery. You can see this takes a while. I need to say this, even though these numbers look huge, 3 years, 2 years, for the different dimensions of recovery, physical recovery, social and emotional recovery, behavioral recovery, and the eating disorder thought recovery. If a young person presents with their first symptoms at a very young age, 12, 13, 14, they've only been ill for 2 or 3 months. It was discovered early on, reported early on, sometimes by the person with the eating disorder, often not. It's discovered by parents, who are the most common ones to discover these days. The treatment is not 2 to 3 years. Recovery often can occur in a 6-month frame. Staying recovered is another matter. But getting people recovered gets them in a better frame of mind. And the earlier it's discovered, the better the treatment is going to go. The longer an eating disorder has gone on, the harder to deal with the thoughts, urges, and actions. Family-based approaches are crucial. As I said earlier, And we know from research that including families improves recovery rates. These are some of the models for treating children and teenagers. All of these models will help parents know how to best support their children. For example, and I think the last slide says this, parents learn not to focus on body image and appearance. Making appearance-based comments is unhelpful. Oh, you're looking healthier is taken very badly by someone who's in recovery, because remember, someone in recovery is still caught in body dissatisfaction. Avoiding good food, bad food labeling. Providing for somebody with bulimia family time after eating a meal, so the compensatory behaviors are sort of are not occurring while parents are sitting with their children after a meal, and parents can provide distraction. Parents and family and friends learn not to be hostile, not to be critical, not to show their anger and their frustration, but to be supportive, because this is an illness, not a choice. Those are just a few of the supportive roles of collaterals. These are the therapies for adults. Cognitive behavior therapy is transdiagnostic, cuts across all the types of eating disorders. I find it particularly helpful because there are so many thought distortions in somebody with years and years of an eating disorder. We can tackle those one at a time. Like, if I go to a restaurant and I'm eating French fries, everyone will think I'm fat. So we go through the cognitive behavior therapy process of basically getting to what's the truth. Are people really looking at what you're eating? You may be looking at what they're eating, but are they even looking at what you're eating? Are people noticing your body? And sort of working on the distorted thoughts. There are many, many distorted thoughts that come with eating disorders. Some of the newer treatments involve families and supportive friends in an active role in renourishing and supporting at home. There is some work on transcranial magnetic stimulation to particular parts of the brain that is under study. And virtual reality therapy is very interesting because you can do exposure work, like seeing foods that have previously been thought to be noxious in virtual reality glasses, so that people are able to do exposure work. Getting to the end here, so recovery and relapse. Sadly, we have a lot of relapse. I don't know how that statistic got cut off, but approximately 60% of people do fully recover from eating disorders with treatment. That has gotten better as our treatments have gotten better. Sadly, there is a high rate of relapse, especially with anorexia nervosa. And it is a reason why people need to be checking in long after they have recovered weight and worked hard on dealing with their eating disorder thoughts and behaviors. So last slide, these are just some practical tips for what not to say to be supportive of somebody that you know who has an eating disorder. And perhaps you might even think of more to add to this list. So you wouldn't say, you look like you've lost or gained weight. I was saying avoid appearance-based comments. You look healthy now. Again, for a person who's terrified of gaining weight, that is a really scary statement. A friend might be doing body comparing, a very common symptom. And so look at their friend and say, well, how long did you work out today? And thinking, oh, well, that's either how much I should be working out, or their body looks like this and I should work out more if I don't want to look like that. It's a lot of body comparing questions that a person might ask. And if a friend asks you something like that, you would avoid answering that question. somebody saying, and this is such a common statement, oh, I ate so much food that I need to go basically exercise it off. That is a sign that the person is having kind of bulimic thinking, which is very, very common. So, discouraging associating with food taken in with any kind of compensatory behavior. Okay, so I'm going to end there, and I wish I could get the bar back. Let me see. I can get everybody back. Questions that you might have about anything I said. I know that was rapid fire.
I'd love to hear you explain a little further the importance of differentiating the type of eating disorder. I assume it has to do with treatment, but I'd be curious to hear you expand on that.
Okay, so one of the factors, since I'll address with teenagers and middle schoolers, one of the factors in treatment is the diagnosis. So we're going to have a little bit different treatment than we are with for anorexia than we are bulimia. Here's the difference. A person with anorexia is much more likely to be egocentric with a disorder. They are looking at life through the disorder, whereas a person with bulimia nervosa would maybe like to have anorexia nervosa, but they're not successful at that. So they are not so egocentric, and they can be collaborative, much more collaborative in the treatment. Can work with you because they can step outside the disorder and look at it, whereas somebody with anorexia nervosa has to learn to externalize the disorder. Another factor for teenagers is age. So family-based treatment, which is the #1 treatment for anorexia nervosa, involves the parents. It's a high level of outpatient care. It is not for many families because it's so labor intensive, but it is only used for teenagers who are 17 and under, live at home, and have less than 3 years duration of illness. And it requires that the family be available 24/7, even missing work and or missing school in order to do that model. So why it is the most effective model, it is also the most labor intensive model for families. And the family works with the dietitian differently with family-based treatment. With cognitive behavior approach for young teenagers, we at least have a teenager who is somewhat motivated. So we have to determine their motivation to recover. For example, if I have an athlete, a hockey player or a swimmer, who really, really wants to get back to their sport, but because they have bulimia or anorexia nervosa, they've been pulled. They are having medical complications. They don't, their weight is dropped. They are so motivated to get back to their sport. They can look at the therapist and the dietitian and say, I want to get better, and here's why. We don't have to do something like family-based treatment with them, because with family-based treatment, it's the parents who have the motivation, and it's often the young person who's avoiding the treatment. With a child who's motivated, we have them on the treatment team actively, and we can do a more individual based with family support model. These are examples of ways that we differentiate. Binge eating disorder with young people is almost always cognitive behavior therapy. There is no family-based treatment model for binge eating disorder. There's a little bit of an adaptation, but cognitive behavior therapy often works pretty well. So if we have somebody that doesn't have bulimic symptoms, is at least in a healthy weight range based on their pediatric growth chart, and all they're doing is binge eating, we can use cognitive behavior therapy with dietetic support. Is that helpful? Yeah.
Thank you.
You're welcome. Other questions? I realize I'm kind of in the blur here. I was just looking at the questions that you asked. Jessica, you would talk about navigation for carers. I want to say just in general that carers and supporters can be immensely helpful with eating disorders, even a spouse. So if somebody, for example, has chronic enduring anorexia nervosa and they forget to eat because their hunger cues are lost neurologically, they may ask a family member to either fix their meal for them, sit with them at a meal, remind them to eat. So supporters are key for treatment with eating disorders. Making connections with people, because eating disorders are diseases of disconnection. They isolate people psychologically.
I think one of the things I would like to ask, but I honestly, I don't think there's much research into it yet at this point.
Okay.
But with all of the hype and you can't go or watch a show without seeing any of the GLP-1 commercials and this big push for pharmaceuticals for weight loss. It seems like there's even more of a fixation on using pharmacology to meet these ideal standards of beauty. Are you seeing any sort of like uptick or relation? I'm sure it's not researched yet, but
well, it is certainly being researched because it makes intuitive sense to all of us that people can treat it just like, the stimulant diet drugs of the 1970s, that people were going to health clinics and getting stimulants to suppress their appetite or using ADD medications still happens. So here along come the GLP-1s, the GLP-2s, and they are being used actively now to manage weight, but of course are being abused.
yeah.
And you can get these prescriptions online, for goodness sakes. So I've seen a little of it anecdotally. Mostly the people that I know that are taking it have binge eating disorder. They've been my clients because they have binge eating disorder, and they also have weight-related medical problems. So it's kind of appropriately recommended. It is taking the place of bariatric surgery in some cases, or being used if bariatric surgery is compromised, the results of bariatric are compromised by binge eating disorder, because people can stretch the pocket in their stomach, or even cause injury to themselves. The GLP-1s sometimes are helpful.
I think it would be curious to understand, because my understanding is the mechanism through how those work is to reduce your appetite, and really, it sounds like it almost puts people off of food completely when they're taking it in the first couple of days. It would be really interesting to understand the long-term effects kind of psychologically when you're no longer taking the drug, but you've trained your body that you don't need to eat.
Yeah, I don't know about long-term use. So it is true that it slows gastric emptying, and it is also true it suppresses appetite. So just anecdotally speaking, the people I know that are taking it, they still have an appetite, but they report not having the cravings, and obviously it slows gastric emptying, are feeling full faster.
Yeah.
Yeah, it'll be interesting to see over time
Yeah.
whether there are negative impacts. We certainly know that abusing a GLP-1 for purposes of weight management is, we're going to be seeing more of this coming along, and leading to things like anorexia,
Of course.
nervosa. Yeah.
And now these medications are being prescribed for some of our loved ones because the psych meds are just so harmful in terms of weight gain. It will be interesting. I think some doctors are prescribing them to some of our folks, and other doctors are just deciding not to. It will be interesting to see how much weight loss really happens when you're you're actually battling whatever the psych meds are doing to increase weight. There must be something going on there that that needs to be satisfied. And, you know, people are about 300 pounds, some of our loved ones. And then the Ozempic-like meds that are trying to, you know, keep them from eating so much. It's a strange mix to my mind, and it worries me.
Anybody know read anything about combining the neuroleptic medications and many of the medications that cause weight gain with the GLP-1s? I'm fascinated that that is happening.
It definitely is happening. And the medications, the Ozempic-like medications, are said to be so helpful to people who have all that weight and all the other issues that happen with that, like fatty liver. I think I've read that that can be a problem, and heart health.
Mhm.
So it's a very difficult situation, I would think, for doctors to prescribe and try to balance it all out.
This is not directly related to what you're saying. It's kind of going back to something that I remembered that I suspected would happen and I'm seeing happen. So for someone who is getting a lot of psychological gratification, brain reward from binge eating, the GLP-1 reduces the craving and the satisfaction that comes with the binge. And I've seen people be motivated to skip their medication in order to have the better binge. So it's sort of a psychological complication when there is even in cases where there's a medical need for the GLP-1, GLP-2, because they're missing the gratification from the binge eating. It's fascinating, but your question is a really important one. What happens when you're combining these two types of medication?
Mm-hmm.
I mean, it does sound very complex psychopharmacologically.
No one has any other questions? All right. Well, I want to thank you, Cris, for being here this evening and for sharing. I learned a lot. It was really helpful. I'm a parent of 4 young kids who are all in that preteen stage. So for me, it was really helpful to learn about all of this. And I appreciate you sharing this with us and taking the time out of your schedule.
Absolutely.
Yeah.
Hopefully my enthusiasm for the topic came across. So yes, I'm happy to be here and thank you for asking me.
Yeah, we appreciate it.
Okay.
Well, I hope everyone has a wonderful evening and a happy new year. Thank you all.
Happy holidays to all. Take care.
Thanks, Cris.
Thank you, Cris. Bye-bye.